So good afternoon, everyone. It's nice to see everybody again, and also our presenter. He has become a regular on our St. John's Power Hour series, number 63. Harlem was actually number 1. Can you believe? Now it's 63 years later. I think that's so wild. I think it's crazy. But this is the 3rd time that Dr. Gunness has been on, and I can't thank you because it's really important. Dr. Gunness is the director of public health at St. John's University, and obviously during a pandemic, we want to be in the know, and you really are so generous with your time and expertise, and it's important. I know we've had conversations throughout this entire pandemic that educating the community the right way so that they know how to combat this virus and how to keep themselves healthy is very important. So I have to thank you. You've really helped us during this pandemic to stay informed properly and to safeguard ourselves as well as our families. So thank you again. I appreciate that. So today, I think the timing couldn't have been perfect. We're seeing that New York is, rolling out. I was just reading an article in the New York Times where they said 39% of the adults have been fully vaccinated in New York, 54% have had at least 1 dose. The fully reopening in July. Hopefully, I read the stats from CDC correctly, and you can correct me, Harlem, if you can. It says 32 million cases in the US and 247 million vaccines have been administered in the United States. So that's quite a feat. But I know I've been watching some shows where I think they were really hoping to be at 50% by April. So I know we didn't make that goal, but if anyone is vaccinated in the audience, congratulations and thank you. I've told my students, I congratulated them for they were vaccinated before they even had the opportunity. And I don't know, this is my personal belief. I'm not speaking on St. John's behalf, but I feel it's a contribution to humanity because I feel that when we are vaccinated, we're helping generations to prevent them from getting sick and also to combat this virus and hopefully eradicate it. And anything that I could do to help. And I said for them that they're helping as well, that they're not only, safeguarding themselves, but they're also thinking of others. So, hopefully anybody who's on the fence or concerned about the vaccine and not getting vaccinated, maybe, Dr. Gunness, you can shed some light for them today. And also, I know there's a question that we already had, and that was something that was in the New York Times article about reopening. And some people think we're reopening so quickly. Florida just said it's dropping all their COVID restrictions. They said reopening could pose an inherent risk to spreading some of these variants. So maybe you could shed some light a little bit on these variants for us as well. So with that ado, I'm going to turn it over to Dr. Gunness. Thank you so much.
Thank you, Susan. It's a privilege and honor to be here. I look forward to Power Hour and look forward to our discussion. My first presentation at Power Hour led to what I'm going to talk about today, which is the study that the sponsored were graciously who supported me in this research, the study initiative. And today is to share with you what my findings are. So let's get to that first. And then we can talk about vaccination and the questions around that and the next steps around vaccination. Let me see here. Can you see the slides?
Yes.
Yes.
Okay, great. All right. Thank you again. It's really a pleasure to be here to brief you guys on what's really going on. in the pandemic world and what St. John's contributions, what we're doing, the moves we're making, and how we're really working to address the needs of the vulnerable communities in Queens, right in our backyard. So I'll share with you my presentation today. So I, as I mentioned to you, my first Power Hour presentation led to funding for a research study to see how the most vulnerable communities or hardest hit communities in Queens have been prepared for the second, third, fourth wave, and now the new variants. So the goal of the research was to conduct a pandemic readiness or preparedness needs assessment of residents in urban communities severely affected by COVID-19. And I specifically honed in on Community District 4, which is Jackson Heights, Corona, and Elmhurst. And I also wanted to see whether we can increase the awareness on pandemic preparedness as well. So at the end of today's presentation, you should be able to understand what the readiness are for pandemic in this specific district, as well as understand the social determinants needs, such as access to healthcare, food insecurity, social support, and social distancing among these residents, as well as identifying the barriers to pandemic readiness and discuss strategies to increase awareness on pandemic preparedness. And that's where the COVID vaccination and discussions will come in. So prior to this study, I think for those of you who are joining us for the first time should really get a sense of what led to the funding and what led to this research initiative. With someone, like myself with a background in pandemic planning and emergency preparedness and bioterrorism planning, I wanted to, from the onset of the pandemic, once the New York City Department of Health started to the data became available to the public, I wanted to
Mm-hmm.
I've been tracking it, and I've been thinking about ways to analyze the data and how it has affected how it has affected communities in Queens. And, being raised in Queens myself, and, I feel the sense to respond or to help in a certain way. So what I did was, my first study, excuse me, was to provide a descriptive analysis of the communities severely impacted by COVID to that of communities that are less affected or moderately affected. And I wanted to sort of hone in on the social determinants factors within them. The other study I did was to examine community level factors among two specific communities, and that was Corona, which had the highest rates of COVID cases in the city, as to that of Far Rockaway, which had the highest rates of death. So I wanted to see what were the factors, the underlying factors that led to so many deaths in Far Rockaway versus Corona Queens. And the other study I did was to understand the self-perception of homeless youth on the COVID vaccine. What are they thinking, whether or not they want to get vaccinated, things of that nature. So all these sort of was a build-up to the study that I'm about to present to you today. So just to give you some brief background, we know that COVID has challenged our healthcare system in unprecedented ways. Public health agencies and healthcare systems have been planning for pandemics for years, but we realized that it wasn't adequate for the rapid rate of transmission that we're experiencing with COVID-19 and the surge of casualties that we're presenting at our healthcare institutions. We also know that New York City has been dramatically affected, particularly Queens, or the area of interest, Jackson Heights, Corona, and Elmhurst, which at one point was the epicenter of the pandemic. Now, just to give you a background on District 4 specifically, it has a estimated population size of over 188,000 residents, and it's predominantly Hispanic. They make up about half of the population there, followed by 36% Asians. Over 63% of the residents are foreign born, and 51% have limited English proficiency. What that means is that they have difficulty or unable to read, write, and speak English proficiently. They also have a higher poverty level at 27% compared to Queens at 19% and New York City in general, which is at 20%. Just to to make note is that some of these studies, the data that I got, it was relatively old, about say 5 years old, and so it may be the statistics or the rates may be higher than what I'm discussing here today. So we know that previous interventions on pandemic planning, from novel virus such as MERS and SARS, often defers to sort of classical public health measures as what we're doing now, which is quarantine, isolation, and social distancing. And all this is to reduce or stop the spread of the disease. We also know that CDC recommends, have certain recommendations for those who are living in close quarters or in densely concentrated urban communities, such as limiting the frequency of performing errands, avoiding contact with a household member who is ill, separating ill persons using a curtain or another physical divider, and use a ventilation system or to ventilate the room, open the windows, put on a fan, things of that nature. We also know that as much as CDC have these recommendations, we don't know to what degree the residents in District 4 have received this information, or whether or not they had the capacity or capability to adhere to these recommendations. So, do they have what it takes to quarantine or isolate for 2 weeks? Do they know how to quarantine or isolate in crowded spaces? Is there preparedness, or are they prepared, I should say, that's a typo right there, for the second and third wave of the pandemic or its new variants? So I decided to sort of look at that to see whether or not they're meeting the basic requirements for pandemic preparedness. And I also wanted to find out whether or not they are aware, and whether or not they have the capacity to quarantine living in crowded conditions. So I did a cross-sectional a quantitative study involving a survey questionnaire. I tested the survey pilot tested it among residents in the community. And when I say I pilot tested this, it was not as simple as, reviewing it with people who were English speaking or Spanish speaking. What I did was I interviewed people from different, represented from different Spanish speaking countries. So they were from Ecuador, Mexico, Puerto Rico, Dominican Republic, Nicaragua, Guatemala, Salvador. So, in this way, I really get a good sense of whether it's the surveys really speaking to them and whether they understand it. Because for those of you who may or may not know, as we have different English dialects across the US, people who speak Spanish also have different dialects, and they may use different terms and have different definitions for things. So I wanted to make sure that in the language that we're using for the survey, that is sort of consistent across the board. And it also serves as an educational tool, and we'll talk about that later on. So for me to sort of execute this study, I collaborated with community leaders such as healthcare agencies, community-based organizations, religious institutions, businesses, and elected officials. And they were able to disseminate my survey via SurveyMonkey to their constituents or to the residents of the community. So what did the survey include? What did it entail? It entailed basic demographic information such as age, race, education, employment, also food security or food insecurity, whether or not you have a 2-week stockpile of food if you were to become ill or you were to be quarantined from the pandemic. Do you have access to healthcare? Do you have access to primary care? Do you have access to an urgent care, emergency room? Do you have medication? Do you have over-the-counter medication or prescription medication? Do you have access to health information? If so, where are you getting it from? What type of social support do you have? what's your spatial capacity? Can you separate 6 feet or more if you share your apartment or home with someone, and also if you share a bedroom, can you also separate 6 feet apart? Do you have pandemic supplies such as hand sanitizers? And what is really your knowledge about the pandemic? And is this research instrument or questionnaire serves as a means to educate you, because by filling out the questions or reading the questions, you are or answering the questions, you are learning something new about the pandemic and how to prepare for the pandemic. So that's where the last question came in, to sort of ask the participants whether the survey questionnaire increased their knowledge on preparedness for the pandemic. So again, the survey was pilot tested among participants, and that's to ensure validity and reliability. And I analyzed the data looking at descriptive demographic frequencies and looking at the different variables to see if there was an association. So let's get to the results. So we see here that those who completed the survey, almost 50% were white, 35% were Latino, and about 10% were Asian. We had 6% African American and 2% other. Is that reflective of the community at large? No, it's not. It's actually quite the opposite, where it's over 60% Latino, Asians make up about 35%, and whites make up less than 10%. In terms of gender, it was mainly women, females who completed the survey at 75%. The large majority, over I think about 85% of participants, were between ages 25 and 44. About 14 were over 65, and about 1% were between 24 and 18 years old. For education, we see here that 61% who participated in the survey were college graduates. And we had about 20% who had a high school diploma, and let's see here. Actually, 11% with a high school diploma, and 20% reported other. So I would imagine other as in some other form of training or education that's not sort of the traditional route. For employment, we have 65% were employed for wages, 23% were not employed, and 11% were retired. Now, going back to education, this is clearly the opposite of what is reflective in the community, where we have usually 60% who are have a high school diploma or less. That's reflective in the community. So basically, what right there is showing you that the study has the potential to be skewed, but I was able to sort of work around that to really get some really concrete findings. Access to healthcare. We see that those who responded, only 83% had access to a primary care provider and 17% didn't. Access to an urgent care hospital, 8% did not know where to go to an urgent care hospital setting. Below, we see that 20% of the respondents did not have prescription medication for 2 weeks if they were to become ill or quarantined from the pandemic. These are some of the basic pandemic readiness. So we see here that 16% did not have adequate food for 2 weeks, 15% did not have water, 36% did not have soap or antibacterial soap for 2 weeks or more, 31% did not have hand sanitizers for 2 weeks or more, and 29% did not have a disinfectant for 2 weeks or more. So as I mentioned to you earlier, you saw that the demographics were quite different in terms of the respondents or the participants of the survey was very different from that of the actual general community. But I was able to then tease that out and separate it among the, while doing the data analysis. And below, you'll see some of the findings or significant findings when I was able to do that to determine really what's the data or the results that really reflect those who live in the community. So we see here that Latinx participants were twice as likely to not have 2 weeks supply of food than non-Latinx participants. Also, Latinx participants were more likely to not have a 2 week supply of hand sanitizers than non-Latinx participants. Food insecurity, this is really big. So Latinx, about almost 25% were food insecure of those who completed the survey. African American, we see that 33% were food insecure. They did not have a stockpile of food for 2 weeks. Social support. Now, this is really big because this is the sort of where the engagement and the interaction comes in when you're ill with the virus and you need someone to help you prepare your food. 40% were unable to identify or don't have someone to help them prepare their food. 29% don't have someone to help them with laundry. And 33% don't have someone to run errands or to help them to get their essential needs. Again, this is really profound because we're thinking almost a year into the pandemic. This study was conducted in September through December of 2020, almost a year into the pandemic, and we're seeing these numbers pretty high. So participants who do not have someone to run errands were also over 2 times less likely to avoid preparing food when sick. They were also less likely to get health information from a credible source. So there you go. We've seen that ripple effect. Not only am I can't, I don't have someone to help me run errands, then I don't have someone to help me prepare food if I'm sick, and I'm not getting the health information that I need from the credible source. So you see these confounding issues that are compounding putting them at more susceptible and more at risk for the disease. So that's why it's spreading and it's not going away because their needs aren't really being met. Participants who are unable to clean a bathroom were 4 times less likely to avoid doing laundry. And we know when we live in these crowded conditions, in New York City growing up, you go to the laundromat. You don't necessarily, it's a luxury to have a washing machine in your apartment. So can you imagine someone who cannot or unable to clean their bathroom, say for instance, they live in a crowded housing and they share a bathroom with others, they were 4 times less likely to avoid doing laundry if they're sick. So not only are they maybe at risk by not being able to clean their bathroom, but also they will continue to be exposed by not being able to avoid doing laundry if they are ill. So let's look at the health information, access to health information, access to COVID resources. So what's striking about this entire study was that over 60% of participants who completed the survey learned something new by completing the survey. Just by reading and answering the questions, they learned something new about pandemic preparedness and how to prevent COVID while living in crowded conditions. And this is very, very disturbing because it is telling, and this is all the participants, which includes educated folks who are well-resourced and folks who are employed. It's telling that the information that's put out there by the public health agencies are really not getting to the communities. And these are essential, critical information to really help them to curb their behavior and prevent the spread of the virus. We also see that 1 in 3 participants did not receive pandemic health information from a credible source. So when I talk about credible source, I'm referring to specifically a public health agency, a public health authority, or a primary care provider or a physician. Other significant findings. So again, what I was able to do, although the studies, the results show that a lot of folks that were educated completed the survey, I was able to sort of tease that out to really hone in and narrow in to see if there's any significant findings. So I found that race was found to be the greatest number, have the greatest number of factors that correlate to poor pandemic preparedness in the following ways. So Latinx participants were almost 3.5 times less likely to avoid mass gatherings. So if they were sick from the pandemic. So basically, if I'm ill, I still have to go out to the laundromat. I still have to go to use transportation. I still have to go to work. I can't avoid these mass gatherings. Also, they were less likely to have medication for 2 weeks. That's a big deal because if I have, say, for instance, hypertension, and I need my medication to last me for 2 weeks, my prescription medication, and I get COVID, that can put me at severe risk for severe disease or death because I can't manage my chronic conditions or my underlying medical conditions that it's often tied to death from COVID. Also, Latinx were less likely to not have a 2 week stockpile of food than other races. Whites and Latinos were also unable to separate 6 feet um, if they were sick from the pandemic, and that's separating 6 feet from those that they live with. So that really speaks to the overcrowdedness in the communities, and that's also the reason why the disease is spreading so rapidly. Age was another factor. So this is really interesting. We see that about 50% of the participants ages 44 and younger were unable to separate 6 feet from the pandemic. That's really telling, and that's probably telling why the pandemic has hit the middle age population so dramatically and so severely in Queens or in New York City. Education was another factor or variable, I should say, that had a significant association with the poor preparedness. So we see that nearly 50% of participants with a high school diploma did not have a stockpile of food for 2 weeks. Over 50% again of participants with an elementary education did not have a stockpile of food for 2 weeks. And 51% of participants with a high school education did not have a stockpile of hand sanitizers for 2 weeks. And also 46% of them with an elementary education did not have a stockpile of hand sanitizer. Again, really telling us that if you are preparing my food or delivering my food, then you don't have the essential supplies to wash your hands or hand sanitize your hands to stop the spread of the disease. And even worse is that you don't have a stockpile for those who have limited education that will last you for 2 weeks. So even almost a year into the pandemic is telling us that the community is still struggling. And this is not reflective of the general community. This is not reflective of the 61% of Latinos and 36% of Asians that live in the community with that may be undereducated or uneducated and have limited resources. So, where does this leave us? So we see here that there is a lack of pandemic preparedness that continues in vulnerable communities. The disparities exist in racial, educational, and in employment groups within the communities as well. There's a ripple effect where residents lack in preparedness in one area are more likely to lack preparedness in other areas as well. Okay. Um, we also see that a large majority of residents learn something new by completing the survey, and residents are not getting the essential COVID health education information from a credible source. So where does that leave us? So weakness of the study, these are things to consider. Methods of the survey dissemination was online, mainly residents who supported and they were mainly residents who supported the elected officials, and they were not fully representative of the community. We talked about that, and I shared with you how I was able to work around that to really get some true findings. Um, Also, the sample size from Elmhurst specifically and Corona was relatively small, and the survey was only in English and Spanish, and we were unable to generalize to other areas for all these reasons. Okay, so what's the next step? So definitely a larger study with more representation of the community, more resources needed in the community, particularly with food, prescription medication, and hand sanitizers, launching a COVID health education campaign, specifically targeted communities using alternate methods other than the online or a website. I mean, that's what's really disturbing about this entire initiative to me, is that we're not using multiple different forms of communication. We're relying heavily on online, where there are communities out there that are struggling, don't know how to navigate online, and we need to find other means to connect to these communities. Also, stronger presence of public health intervention is needed. We're really not seeing it, and if it is, it's happening in fragmented um, circumstances, and really not consistent and sustainable. So to end the discussion or the presentation, this is one of the first studies, to my knowledge, that really examine basic pandemic preparedness in one of the hardest hit communities in the US, as well as crowded urban spaces. It really, it's providing a snapshot on the status of preparedness in the community. And I think that this is just really a little example of what's really happening. The communities, they still continue to struggle, but this is just a really little, bird's eye view, if you will, of what's really happening and the devastation the COVID is causing in the community. Also, this study opens a discussion of urban pandemic preparedness and planning for the scientific community, to really help to bring awareness to the community as to where they're at and why they're struggling, even after 1 year of us having to deal with the pandemic. I would like to acknowledge the sponsors, St. John's University sponsors, who funded this project. None of this finding, this initiative, this research could have been done without your support, believing in me, for Ms. Susan Damiani for trusting in me that I'm able to conduct the study and do it in a timely manner and bring the results as I'm sharing with you today. Susan, you have been an incredible help to the public health program, to this study, and many other initiatives that we're working on. I couldn't have done this without you at all. Also, Dr. DeGates, Dr. Wu, the elected officials who agreed to disseminate the surveys for me, as well as the community partners and community leaders.
Well, thank you, Dr. Gunness. And I have to thank the McAllen Society members. When we approached them about this project, they were happy to help. It was in the heart of the pandemic, and everybody wanted to do something, and you're sitting home and you don't know what you can do to kind of help the cause. And you gave us an avenue in which St. John's could be there for their neighbors and for their community, to try to uncover why, this particular communities, and actually it turned out one of the communities where I was born and raised, why it was so hard hit. It was sort of the epicenter of the epicenter, correct?
Yes,
Yeah,
absolutely. Yeah, it was
yeah.
ground zero. Yeah.
Yeah, and I don't think anyone really knew about Elmhurst Hospital, but I think the entire country certainly knows that hospital now from the news and from, all the cases that were flowing out of that particular location. So thank you so much. And I know there's another phase two, which we're, talking to our original donors to see if they will support you, because I think a public health campaign is needed, because the results show that there's more education, correct, needed
Yes.
in order to combat this. And I know even for myself, and I have to say, I speak to educated people as well. So it's not even people who maybe just have education up until, the sixth grade or something like that. I don't think it has anything to do with that. I think it's the information that's out there. Again, my belief, my personal belief, is not consistent. These rollouts and all of this, like sometimes they say, maybe we can roll out this month and then it's 3 months later. And so I think, people don't have, I think, 100% faith in the healthcare system, as much as what they did was an amazing feat to get, all these people vaccinated up to this point. There's still a lack of trust. And, as a public health director, I'm sure you've seen this when you worked on the Ebola and all of that. How do we overcome, that fear factor, or how do we build that trust with the community so that they can feel good about the decisions that they make for themselves and to safeguard themselves? I guess that's the first question in
Mhm.
all of this.
That's an excellent question. And having worked in public health for over 20 years, it was different communities at different levels, from community-based organizations to the federal and military level. I would say that, and I'm actually talking to the local programs, some of the local programs in this hardest hit communities. And what I'm learning is that they are the resource and they have the information on how to best address it. The problem that we're having is that it is so fragmented, where I'm learning that the city had a vaccination mobile van in the area, but only for a week. I'm
Mm,
learning that agencies are sort of really pulling and scraping to get resources to bring to the residents who are very needy. They work 3 and 4 different jobs. They can't get the vaccine because they can't take so much time off. There's no fast track for them. I'm learning that they don't know that the vaccine is available and the van is there for that week when the van was there. So these agencies have the resources, or they know to connect the dots. So for a perfect example is that when they did have a mobilization, a vaccine mobile van in Jackson Heights, um, they what an influencer in the community, in one specific community, the Nepalese community, went on Instagram Live and went on Facebook Live and said, "Hey guys, look, I'm here and I'm about to get vaccinated. Come join me." And that
mm,
made the difference.
say,
She
yep.
had a following. And the same thing we need to do for the education. In these religious institutions, in these, and not just religious, social, agencies and social support agencies, really to massage the idea and have the subject matter experts to speak to them in their language, to really share with them what's really happening. And what I'm also learning is that different groups, different ethnic groups, different racial groups, different social groups, and it doesn't really matter your educational status,
Right.
but they have certain beliefs that they need to understand and that needs to be addressed. And if we don't address these needs or these questions or concerns, then they're not going to come to get vaccinated. And
Right.
we're learning this as we go along, which leads to my next initiative, which is really to develop a health education campaign, a COVID vaccine education campaign to debunk the myths. So this is really, addressing the myths that are going on there, and to address it with the actual facts that we have and the information that we know in
Right.
10 different languages. And it's, again, not only just 10 different languages, but we need to understand what are the specific concerns in these communities.
Right.
Right? For instance, Susan, you and I spoke about this, whether in the Catholic community, and, we have to understand the needs of the communities. We need to understand whether anything or any ingredient in this vaccine is sinful, if you will, or have something that it's against my strong beliefs and my
Mm-hmm.
convictions, right? So, for instance, among Catholics, they wanted to know whether or not the vaccine was made out of aborted fetuses, right? Which is
Mm-hmm.
not the case. So they wanted to find that out, and because that would be a barrier towards vaccination. In other
Exactly.
communities, they worry about pork ingredients in the vaccine, or beef, things of that nature. Other communities are worried about, whether there's an issue with, can I get a vaccine if I'm an immigrant or I'm documented or undocumented or things of that nature. Other communities are worried about, the government, where should I trust the government? Because they have ruined it for our communities for decades and for
Right.
centuries and
Hmm.
whatnot. So how do you then address these issues? So I think the answer is the answers are in the communities. What's not happening is someone to connect the dots, and I think that St. John's can do that. I think we do have the
I agree.
resources, the connections, the
Hmm.
working and having studied this community for over a year now.
Right.
I'm understanding how the community functions and the different functions within the community. And that's the beauty of working with the elected officials, where they can help me to sort of tap into the resources within the community. And that's how I'm learning about who's doing what and who's not doing what. The other thing I found out was that Community Healthcare Network had a mobile van. Now, I'm on the board of directors for Community Healthcare Network. I did not know that they had a mobile van. So I contacted them immediately, the executive management, and I said, well, where was the mobile van and how often were they functioning and what can we do to make it more sustainable? When you have
Right.
more sustainable resources in the community, then you will see the trust. If you have a van by the Catholic Church and the Catholic Church is supporting and endorsing it, you will see people coming out to get vaccinated.
Right. Exactly.
You'll see people
Hmm.
believing in the process if the leaders of the community they believe in the process. So this is where the
But
health.
but why 1 week? Is it because of lack? When you say, is it lack of resources in terms of money? It costs money to get a mobile uh, vaccination going? Uh, is that what it is? It
Yeah,
takes the money, or is it because to get volunteers? Because I know my sister, who's a nurse, it was very hard for them to recruit people to even give out, to administer the vaccines and to help with the process, the vaccination process. They were scrambling, to get people. So is that too the manpower, not only the money?
yeah. So when you think of a public health initiative, and you think of something novel like a new pandemic or a new outbreak of a disease,
Mm,
it requires an infrastructure, and
right,
if we don't have that infrastructure in place, then that's where the issue comes in. It's not just the money; it's having, like you said, the volunteers, having the staff, having you having the resources for it to be continuous, right,
right,
on an ongoing basis. But I'm a little bit kind of alarmed, I should say, because we know that this is the hardest hit community in Queens,
right.
if not New York City,
Yes,
and we don't have dedicated resources for them. So my push that I'm actually working to behind the scenes on now is to pull the resources from Community Healthcare Network, from New York City COVID vaccine program, as well as what I've learned in the communities and the different agencies that are serving the underserved residents, to really bring all these resources together for us to have a planning committee, if you will, and execute a mobile clinic that will be there and present there in Jackson Heights, Corona, and Elmhurst. So people know, oh, just go down the block or go
right.
to 74th Street. That's where the clinic is. Go and get your vaccination there. The van is right there. They're operating, right? So
Well, I
that's,
don't know if you saw, there's a Spike Lee commercial for Uber, because now Uber is, donating their time and they're taking people to the vaccination locations, which is great. But now they say that they're putting it in more pharmacies. But I think, like you said, that's great for car service, but I think people are capable of walking to a vaccination site. I don't think they need car service unless obviously they're, disabled. But place these vaccination sites in accessible areas like your pharmacy or other areas as well, so that all they have to do is walk down the street. Like you said, it has to be made accessible, even for me. I got vaccinated sooner than I thought, thanks to a very good, my employer, St. John's. It was really a great resource that they provided to their employees, and I'm grateful for them because I probably wouldn't be vaccinated right now, to be honest with you. Not that I don't want to, but it was so easy. How could I say no? I just
Right.
walked in, got my vaccination shot, and then that was it. So I could see if you make it easy, because I'm a busy professional. Everybody's busy, although, this is important. We should make the time for important things. But again, life does get in the way. So the easier you can make it for everyone, the better. And like this attendee just said, it's interesting to see that there's a push for resources in these areas. However, the lack of communication and promotion prevents these resources from being used. On PR and marketing, you could clearly see that that is the weakness. They're not getting the message out enough. And I don't understand why. I mean, we should see it all over the news and TV and
Yeah.
billboards and everything else, but I don't really see anything in my neighborhood.
And I had an interview with New York One last night, and that was sort of what we were talking about. But going back to your comment about Uber and Spike Lee and the cab service. Now, I have been talking to an agency that has responded, and it's a media agency in Queens, that in Jackson Heights, is responding to the needs of the community, of their community. And that topic came up, and they said that it's not going to work. You can't take someone
Mm,
from Jackson Heights in an Uber,
right,
schlep them for a whole day to go down to South Jamaica to get vaccinated. It's a whole day
right,
process
right.
versus just going up into a mobile clinic right down the block, as you said, or a pharmacy and getting myself vaccinated. It's not going to work. They don't have the time. These are people who are busy, more busy than you and I,
Exactly.
because they need to make a livelihood.
Right.
Because if they don't go to work, they don't have sick time. They don't
Hmm.
have,
They don't have food on
unused
the
benefits.
table.
Exactly.
Yeah, that's crazy. No, I know. And I even for like to share a personal experience, like with my mom, she can't walk too well. So everybody was like, you don't have your mom vaccinated, but my mother couldn't go to Javits Center and all that. But what I saw for women at my mother's age, and she's in her late 80s, the familiarity of her going to the pharmacy. And as soon as we went to Walgreens, she knows the pharmacist, and they knew her, and they knew her limitations. And it just made it easier, and it made it more comforting for her to take, older people and bring them to the Javits Center. It's big. They've never been there. They're going into a different area, like you said, from Jackson Heights to South Jamaica. That I think was a little bit too much for to be asked of the older people. I don't understand why we couldn't get these vaccines right away into their local pharmacy. It's in their neighborhood where they're comfortable with, because already they had this fear of taking this vaccine, and now they have to take it in an unfamiliar environment. Again, I understand we weren't ready for this and we were doing the best we can, but if God forbid we ever have one, and let's hope we never have another one, we should be prepared to really, and continue to administer it locally in the local neighborhood, so everyone can go to where they know their neighborhood pharmacist, or their local hospital, whatever it may be.
And that's
That makes it easier.
a key: local, local, local. How do
Local,
you make
yeah.
how do you bring the resources to the
Hmm.
local community? So I wanted to
Right.
address your question about the different variants, and this is
Hmm.
also where
Right.
the fact sheet is going to be helpful,
Okay.
because that question comes up. Well, why would I get the vaccine where then the different new variants and things are changing?
Hmm.
And I'm hearing this and this, the variant is scarier than that variant, and this one is more infectious and more deadly than the other one. The bottom line is that the vaccines were created in such a way that it will help protect you to some degree or the other. So it's better to get the vaccine than to not get the vaccine at all,
Hmm.
because we're seeing with the vaccine, including the Johnson and Johnson, that it really is to help to reduce severe illness and death. So if we can reduce severe illness, prevent ourselves from going into the hospital to be intubated, and or dying from the virus, then that really is a lifesaver. And that's the benefit of getting these vaccines. So even though there may be different variants, um, it
Right.
it should be able to help you to some degree or the other. And that's the yeah. So that hopefully will help answer that question,
That makes sense.
because the studies have shown that it can prevent severe illness and or death, right? In the majority of people who are getting vaccinated. Yes, I've worked in infectious diseases for again over 20 years. There are circumstances where our bodies, each and every individual, we have a different body makeup, right? And I've done investigations on measles cases where they did get vaccinated, but it was not, they didn't develop a full immunity to it, even though they received the proper vaccination when they needed it during the time, the second dose, the booster, et cetera, et cetera. That's just how certain people's body works. But for the large majority of people, the vaccination works, and it works very effectively. And that's where the more people get vaccinated, you'll see the decrease in the hospitalization and the severe illness and or death. And that is helping us and helping our healthcare workers, right? Because in this way, they're not
Hmm.
inundated with cases that are showing up, and they can attend to their normal, heart attack or stroke
Right.
victim, right? So that's where the problem is, and that's where the fear comes in. But if we don't provide the proper information and education in the proper way, in the proper manner to these communities, then they're not going to get vaccinated. The other question came up, well, I never got the flu vaccine, so why should I get the COVID vaccine? So, they're two different things that we're talking about.
Yeah. Well, I never got the flu, but I felt like this was a different case, a different situation. So that's why I did it. And also, I feel that if you want to travel, there's going to be a lot of countries. And what's your thought about that? Like a lot of countries are probably going to ask for your vaccination card. There, I mean, before when you traveled, there were some restrictions when you traveled, you had to get shots for certain countries. Now it seems like there's going to be a lot more countries that you're going to need this vaccination card. So if you want to travel, if you're not vaccinated, I don't know if you're going to be able to get in with just a COVID test. Do you agree with that or no?
Yes, absolutely.
Mm,
Absolutely. I
right,
think that the more we push this out, the more, countries may then start asking for, the vaccination, or it might be in our passport, vaccinated.
I know that's what they said. A different type of passport you
Yeah,
may have to get.
yeah, it may
I
be,
know.
but I think there's a good question about what recommendations do you have for those with young children? Is it okay to visit their
Right. I
grandparents in
was
mass?
just
And
gonna. Right.
definitely mask, okay?
Hmm.
Now, you have to wear the mask because the virus is very, very tricky and very conniving and very manipulating. So the virus is sort of your worst enemy, if you will.
Hmm.
And this is how it works. So even if your grandparents are vaccinated, guess what? They may still be able to carry the virus. The
Yes.
virus sheds.
Hmm.
Think of the virus as dandruff, if you will. It sheds, right? So
That's a
it
good
will,
way of looking at it. Yeah.
yeah, it sheds. You may not even know it's shedding, but it sheds, right? And so you get the vaccine, the grandparents get the vaccine, and they shed it to the kids. Okay, then the kids can get get the virus. So that's why you want to wear masks. You want to continue with your basic pandemic measures. Wear masks, socially distance. Um,
Okay, but let me ask you this. It looks like Pfizer might be getting a vaccine where we're going to go as young as 12 years old. Is that what that looks like? As young
I
as
don't know.
12?
Yeah, I don't know, but
Yeah, I
uh,
saw something where I read, I think it was 12 years old. So any children that are younger than 12, so far there's no vaccine. However, has there been, I mean, I'm sure there's been cases, but overall, what happens to kids if they should get the COVID if they're 12 years and under? Has there any been severe cases, or are they just getting a cold? Are they getting flu-like symptoms?
yes, actually, great question. Hold on a second. Let me just plug in my laptop.
Sure.
So,
Hmm.
great question. So, it's the same thing applies to, um, to kids. If children have underlying medical conditions, they may be at risk for severe illness or death,
Mm-hmm.
unfortunately.
Mm.
We're not immune to this necessarily, right?
Right.
Although the large majority of us who do get it recover and continue with our daily lives. There are others, though, who have gotten sick or ill from the virus, or infected, I should say, and then they, lost their sense of smell or lost their sense of taste, and they have prolonged loss of sense of smell or taste. These are not being captured, so, do you want to continue living without a loss of sense of taste or smell or things of that nature? Do you just want to just, prevent yourself from getting it?
Mm.
And do you want to risk your child getting it? The other thing to also think about is that, you know, we all know that, a lot of us may be healthy and, not even want to go to a doctor for a primary care visit or things of that nature. I mean, if some of us may have underlying medical conditions that were not diagnosed. Some of our
Mm.
kids may have underlying medical conditions that are not diagnosed. So that's where it's important that they wear the mask, and if the vaccine is available, then offer it to them. If not, then continue with your pandemic precautionary measures.
We have here, I don't think schools should require them like they do for the MMR vaccines. Perhaps we should wait to see the effects on children, but young adults and older should be vaccinated.
Yeah. So that's what's causing the vaccine hesitancy, to be honest with you.
I know.
Although we have what over or close to over, well, the studies, the Pfizer Moderna studies had what 40 and 30,000 people who were vaccinated
Mm-hmm.
to see what the results were and the side effects and things of that nature, if any. So to roll out the vaccination for the children, they had to have tested it, and they had to have it had to go through a clinical trial and an FDA oversight and vetting, just like we did for the adults. So if the vaccine is going to be made available to folks who are younger than 16 years old, then that would definitely have to have gone through the similar rigorous process as what FDA will require for any other new drug or new vaccination. It may be
That
expedited.
makes
It
sense.
means that normally it would take, 2 years to go through something, but because of the emergency, now this is an emergency. This is not, remember everyone, we're in emergency mode and we still are in emergency mode. So think about that. In an emergency, a fire emergency, for instance, what do? Grab your essentials and run, right? In a
Right.
pandemic
It's true.
emergency, then what you do is that you use whatever essential resources and measures you can to continue with your life as normal as you can.
Now, there's another question here, just to keep it with students and all of that. It says here, St. John's has required that all students and staff be vaccinated. I don't think it's required staff. I think all students to be vaccinated against COVID for the fall 2021 semester. There are many individuals that are vaccine hesitant in the St. John's community. Do you think this mandate will amplify the fears about the vaccine? What can St. John's do to encourage people to get vaccinated? Again, I think they just have required the students. I'm an employee of St. John's, and I haven't received anything that told me that I'm required to be vaccinated uh, before I go back to the office. I don't know, can you clarify some of that information?
No, I do know that it's expected that students get vaccinated. I think that
Hmm.
that's a very, very good question that needs to go back to the planners at the university or the decision makers in sort of encouraging folks to get it. I think that I don't know, what I would say is that it's a policy of the university, and if they're enforcing that policy, then then definitely talk to your primary care provider, and find as much forums as you can to address the question. Talk to your faculty, talk to your, not faculty, talk to your professors, talk to your program directors, talk to your advisors about it, and be a voice for your community, be a change agent for the students, for your peers. And I will certainly take that up the chain after today's call, to let them know that this is a concern and we need to get more information and education on the COVID vaccine. I think that that's a very, very good question and a very important question.
Yes. I'm going to switch gears a little bit. This question has to do with your study. So the hardest hit communities in your research willing to get vaccinated, especially after being affected by the pandemic?
I don't know.
Mm.
And that's where the concern is. And I think there's when we think about vaccination and we think about willingness to get vaccination, this speaks to what Susan, you and I are talking about now or earlier about accessibility. If something is accessible to me, I'm more than likely to get it, even if I'm hesitant. If the information is out there where they can address my concerns and my needs, then I'd be more than likely to get the vaccine. But if it's not accessible, if I don't have the information to address my concerns, if I don't have a trusted member, when I was doing the Ebola response out of JFK Airport, I had to convince the executive cabinet of the airport, all the decision makers, the directors of the different airlines, of the different agencies that are represented there, from Customs and Border Protection to TSA to you name it. I had to Port Authority of New York, New Jersey, Port Authority police officers, Port Authority operations. I had to convince them that we are going to run an Ebola program out of JFK Airport. And the best way I was able to do that was to go around. In public health, we call it outreach and education. In business, you call it marketing and advertisement. To really go around in every different agency head, educating them with the subject matter experts, with three different uh, um, subject matter infectious disease physician, three,
Wow.
in meetings, to every departmental head, to every director or executive director, and to educate them and to share with them what we're doing, how we're doing it, the purpose we're doing it, to protect the airport community, to protect their employees. I even had the physicians who were deployed working with me to educate the cleaners, because the cleaners did not want to go into the airlines to clean it at all, especially with a plane that came from an Ebola affected countries. They were not going. And we were able to then, sort of, massage the idea and the concept and the education by wearing the proper PPE, personal protective equipment. You were then able to then convince them to change their behaviors to then respond and get clean the airline, but the airplane. But these are some of the things that needs to occur that's not occurring. Do we have the resources? I don't know. Do we have the information? I don't know. Sorry, we do have the information, but is it getting to the community? That's the problem. It's not really getting to them as it should.
What about, um, I know a lot of people who haven't gotten the vaccine because they've gotten COVID and they feel they have the antibodies, although they've been tested, they haven't been, they were tested maybe 6 months ago. They haven't been tested recently. If you have the antibodies for COVID, or you think you have the antibodies for COVID because you had COVID, are you protected against the virus?
That's an excellent question. That's a
Mm.
very good question. I would strongly recommend vaccination anyway, because the vaccination, again, with the new variants, you may not have had that
Mm.
variant. So if you
Mhm.
do get a different variant, your body may react to it differently, even though you have recovered superbly and went about your business. I think that I would recommend getting the vaccine because, again, that vaccine is really to help in your body, you have defense, systems and mechanisms. And when you get the vaccine, your body is becoming friends with it and marrying it, if you will, inside your body. So that if something similar comes in your body, the vaccine would say, your body's going to say, stop. This is not happening in my house. This is not happening in my body. Get out of here.
Right.
Right? But if you don't, then, and again, you may have different variants that you may be exposed to in the future. Okay, so that's the issue with not getting
I see.
vaccinated.
Okay, that I did not know. There's also another area, the young, another group, the young women, concerned about infertility or birth defects. Have you seen anything in your research? Um, Someone said, I believe this happened in the 50s with the drug. So you see, people don't forget.
Yes,
They don't forget these things
yes.
that happen, and they're going to apply one drug and they're going to apply it to the other, like both drugs are the same. So that I know is another fears that are out there.
Well, I think this sort of discussion that we're having is what really needs to also occur in the communities that are dramatically affected and that they're not getting. And I think to address that specific question about breastfeeding and birth control, the pediatricians as well as GYNs, obstetricians are recommending the vaccine. As a matter of fact, my friend was hesitant of getting the vaccine, who who is breastfeeding, and then talked to her. I saw her recently, and she said she's gotten vaccinated because her doctor recommended, and because by getting vaccinated, you are then transferring the antibodies to your child through breastfeeding.
Mhm.
So that's the beauty of it. And
Mm.
I don't know, I can't speak to whether if you're immune and vaccinated and after childbirth, if your child will be then immune to it. I can't speak to that. I don't know what the science is around that, but it's coming up more and more that it is recommended for women of childbearing age as well as feeding women to get vaccinated.
What about what people say? I'm not getting vaccinated because this happened too fast. It's not approved by the FDA.
Yeah, so that's where the in time again in my analogy with, if there's a fire, you run, right?
Right.
And this is a pandemic. So in the pandemic, what the FDA did was, and it's a public health emergency, and that's a difference. Okay, it's not a regular cold. It's not, the flu that we have studied for so many years, et cetera, et cetera. It's a public health emergency, and this is all about saving lives. So they had to, yes, the drug the vaccination was rushed, but it was rushed. It did not skip necessarily the process that it takes to test the vaccine.
Right.
And that's how we can tell there were 30,000 plus and 40,000 plus in each respective clinical trials. And that's how we were able to sort of determine whether or not what type of side effects people were experiencing on the first dose and the second dose, and with Pfizer versus Moderna versus Johnson and Johnson. And that's how we can also determine whether or not the different types of side effects, if people were to experience it, and the severe side effects. So we know if you are known to have severe side effects from any type of vaccination, you definitely want to consult your provider,
Of
right?
course. Hmm.
Um, you know, can I say that it's going to protect and, no one, 100% of us are not going to have side effects? No. In the real world, it doesn't happen that way. In the real world, you may take a cab driver from cab driver X, a ride from cab driver XYZ, have a wonderful time. I may use that same cab driver. He may be having a bad day, and I may have a horrible time. And so
It's true.
we can't go on that. We can just go
Right.
on what the studies are showing for the large majority. And we also know that when you do any study, there are so many factors that we have to consider, right?
But let me ask you, Harlem.
Mhm.
It says COVID-19. So this is not something new to researchers, the
Correct.
coronavirus, right?
Correct.
So it's not, see, because from what I get from my friends who don't want to be vaccinated, they're getting a sense that, this is the first time we ever saw this, and they don't know anything about it and so forth. So I feel like the researchers and the scientists at least had some knowledge because it's COVID-19, right? I
Very,
don't know,
very good point. Very good
right?
point. Yes. So the mRNA, right, vaccine has been studied for many, many years. Um, Going back to your question that the COVID virus is not something new, um, for those of us who remember SARS, severe acute respiratory syndrome, and MERS, the Middle Eastern respiratory syndrome, those are families of COVID.
Right.
Actually, SARS stands for SARS-CoV-1. COVID-19 is the scientific name is SARS-CoV-2, I believe. So, when you think about that, we have a history already of this virus,
Right.
of the infection, which has been studied before, which has been tested before. So,
So we've already started it. That's
yes,
the way I look at it. I mean, I worked in clinical trials. I worked with clinical coordinators. I know how long it takes for a clinical trial from start to finish. I hate to say it with the bureaucracy and FDA. There's many drugs that Europe is using that the United States, doesn't use. And it's not because we're afraid. It's just a holds up for all kinds of reasons. So if you pump billions of dollars, which we did, into this testing and everything, of course they got it done a lot faster. People don't realize we
correct.
probably could get everything done
We can get
this fast.
anything
So it
done if we
doesn't
can.
mean it's ineffective. I can't say because I'm not official, but is that correct, or am I talking to people, out of
I
context?
think you're right. I think if you do have the right resources and you do have
Hmm.
the right infrastructure, then we were able to then get the vaccine out in a reasonable time. And I think that we have done an incredible job in the US with the vaccine. I'm very, very impressed by how far we reach in the numbers. My only concern is that what happens now, usually, I think I mentioned this earlier, people who are more, they're volunteer, and those are the good patients,
I know.
right? The good patients are, yeah, yeah, I'll get the vaccine. Yeah, yeah, I'll
Right.
take the shots. Yeah, yeah, I'll do this. Whatever you want, doctor, I'll get it done. I'll get the test done. But what about the not so good patients who
Mm,
don't go to their annual physical? What about the patients who don't get your other vaccines, right? The flu shot, or a lot of us don't get the flu shot. So what about those? How do you get them? That's a challenge now, and I think that
mm,
that's where you'll see a turning point where
mm.
everyone is available and the vaccine, and I'll go set up online, I'll go get it, I'll drive 2, 3 hours, I don't care, I'll go and get the vaccine. But now, what happens to the others who are sort of sitting behind, watching and waiting? What happens to them?
Mm. No, it's a big undertaking. There's no, way about it. And I really thought by now, I'm so hopeful. I thought we would be at herd immunity by now. How long will that take us? So now I'm reading they don't think we'll ever get to herd immunity.
Again, the virus is only a year old, right? A little over a
Hmm.
year old.
Right.
It's only a little over a year old, this new strand of this new virus. And it takes a while. It takes a
Mm,
while for it to sink in. And it is the challenge for the public health community, as in the case with even measles. We do have, certain populations and groups who are against vaccination for the measles. So this is where the challenge comes in for the public health officials and the public health agencies to really develop sophisticated, innovative means and or traditional means of
mm.
really going back to old school, perhaps. I don't know, but finding means to really connect to the communities and to build that relationship and that rapport to get them vaccinated.
I
Yeah.
would love to read and to go back to when polio was around. And they have the polio vaccine. and we don't have polio, correct?
Correct.
So, I mean, I look at that as a good example that we
Yes.
were able to eradicate polio.
Yes.
Everyone was online and took the vaccine. So I don't see, the difference. And the measles, mumps and rubella. I mean, we took the vaccine and now we only see cases of it because, like you said, people don't want to be vaccinated for measles and for mumps and all of that. So that's why some of these diseases are popping up again, but we were able to eradicate that. So I don't see where this is any different.
Well,
So it's interesting.
it's very different, Susan.
It
Think
is,
about it.
yeah.
Yeah, think
Mm,
about it this way. Not really about the initiative or about the disease itself, although that's also different. But we're in a different age and a different era. Everything now is very virtual. Everything now
mm,
is all online, and that's where the misinformation is spreading, and it's spreading rapidly online. Someone sends a video, or someone's
it's true.
some quote or whatever, and it gets from one text and it spreads like wildfire, and it gets from one text to a next, so one link to the next link, and it just goes, and it goes rapidly, and it goes, in before you know it, it's all over. And that's why YouTube has so many hits, for whatever silly video that comes out, or Instagram, or
Hmm.
whatever. If it's all about immediate, exposure, and it's global.
It's
So,
true.
so
Right.
back in polio days, when we got vaccinated, we didn't have that access to that information so rapidly and so quickly and so vast to spread.
No, that's so true because I always see doctors always saying, now do me a favor. When you go home, do not go on the computer and look this up and all of this because, that they come back and probably driving their doctor crazy with all this. I think I have this, everybody self-diagnoses themselves now when they
Yes,
read stuff on the computer, which is true. And you didn't have that back in the day, the polio days. So that's very
correct,
true.
correct.
Yeah.
So we're different time, different day,
Right.
resources are different, our knowledge, our education,
Hmm.
people are more educated now, more knowledgeable, more access to resources, things like that. So, and there are also regulations too, for people to make decisions. Right now, COVID, a university can have a policy to say all students must be vaccinated. But we can't say, when every state have their home rule, so we
Right.
can't mandate that.
Hmm.
Across, little countries are able to do it.
That's
They have
interesting.
different
I
rules.
was I was
Yeah,
talking to someone from Israel and I said, "Wow, you guys have been doing a fantastic job." And he said, "Well, you can't really compare us to the United States." He goes, "The way I look at the United States is it's 50 countries."
correct.
And he said, "We only have 4 HMOs." So we were able to organize everything and get, everybody vaccinated. And also they're not letting anyone into their country. So that
Correct.
helps too. I was talking to someone from Australia and they can't come and see their son graduate at St. John's because in Australia, they have to go to the government and get an exemption. And it
Hmm.
has to be a
Hmm.
really good reason of why you're leaving Australia.
Hmm.
So that's why Australia's probably been doing well too. But these are severe restrictions. I mean, they're keeping people in their countries and they can't even go out of their country. So I don't know. I mean, that's another probably discussion for another day is, we can't live life in a bubble forever. We have to start living our life. So when does that happen? Um, when is it really going to be where we're really out of danger for everybody, not
When we
just
go,
certain states and so forth.
when we get the people herd, when we get herd immunity,
And that's
and
getting the people vaccinated.
then getting the people vaccinated.
There you
That's
go.
it. Yeah.
So if anyone would like to help Dr. Gunness come to, with a powerful public health campaign to get the word out, to talk at your churches or wherever you have organizations or women's organizations to combat the fears or the misreporting, I should say, he needs our help. So please get in touch with Dr. Gunness or myself, because that's for the next phase. We're definitely looking for everybody's support for that.
Great, thank
And
you.
someone brought up India. Let's pray for India. I really feel badly for them. I really do.
Yes, yes, absolutely,
Yeah,
absolutely. A
yeah,
prayer goes out to India.
definitely.
Yeah,
They're having a tough time right now, no
yes,
doubt. And Europe, they're still
yes.
not. They're slowly getting it together. So we'll hope. But thank you everyone for joining us. I hope this was informative. I know we made sure we answered everybody's questions. So thank you again, Harlem. We appreciate your expertise and informing us better.
Always great to see you, Susan.
All right.
Thank you very much.
Thank you. Take care.
Okay,
Bye-bye.
bye-bye.
Bye, everyone. Have a good day.